Why are you telling her to be quiet? I can't even hear her.
For future reference, in the next 30 minutes before she has to leave.
I think she should walk by and hug you while you're talking.
She could. Do you hear a little reverberation in the background? My dishwasher is way back in the background. Can you hear it?
Cannot.
Okay, I won't worry about it then. It's like at the end of the cycle, and if I stop it now, I think I'd have to start over. Anyway, okay.
So, hey everybody. We logged in 2 minutes early, so we're just letting everybody get started, but we will start on time today. Y'all get to hear the fireside chit-chat of Christy and Dr. Evan.
Like the old days.
Like the old days. This may be all we have for a while. It's heartbreaking.
Do you find that people show up more to webinars these days since it's all they got? Or is it about the same?
Oh no, attendance and registrations are through the roof.
Excellent.
You didn't even ask how many people registered for your webinar today.
I wanted to.
Do you want to know?
Okay.
840.
See, I'm slipping. I mean, from 5 years ago.
I mean,
that's not too shabby, though.
It's not too shabby. Pretty sure that my webinar on Thursday is going to smoke you, though.
I've given up on, competing. I'm comfortable with who I am.
I'm just saying. Okay, it's time to get started. Hi, everybody. Y'all know that it's going to be really funny for these people who watch the recording and they just hear Evan and I chit-chatting about random stuff. Unlike the rest of y'all who were like, I told y'all we had to start early because we almost lost the room. But anyway, for those of you who do not know my very dear friend, my brother from another mother, Dr. Evan Gwilliam, he is a graduate of Palmer College of Chiropractic, and he's kind of a smarty pants. He was the valedictorian. But I didn't have to tell you that for you to know he was a smarty pants, because honestly, he has like 1,000,001 like certifications because he's kind of a junkie. He's a certified professional coder, an ICD-10 instructor, medical compliance specialist, a certified professional medical auditor, and a whole bunch of other stuff behind his name. He also has a bachelor's degree in accounting and a master's of business administration. He's a real popular speaker. I might have been a hair more popular than him this year. I'm just playing with him. But he does provide expert witness testimony for medical records audits, does consulting, does a lot of online training, because he really is a smarty pants, because he's like one of the smartest people I know. And he's fun, and he's a really good teacher. So everybody, I'd like to introduce you to my dear friend, Dr. Evan Gwilliam. It's all yours, Evan. Let me start your slides, dear.
Thank you, Christy. Well, it's terrific to be here with you guys, and it's nice to have that introduction. I like to sometimes sit and stare at myself in the mirror and convince myself I'm a smarty pants. It's my affirmation. You are a smarty pants. So I hope you guys can all do that for yourselves by the end of this presentation today too. Today, I want to talk to you about rock solid care plans. And the reason I chose this topic is because I think it is perhaps the most important thing you can do in terms of record keeping. I want you to be able to feel like your records are solid and have a good foundation. And so that's hence the name, Rock Solid Care Plans. Now, I am the clinical director for PayDC, which is a chiropractic EHR software that does documentation and billing and other things. And my contact information is there if you have questions about that. But let's get into this. If you have a lousy foundation, then the rest of it doesn't really matter. And there are some of you on this call who may be worried that you've been able to have patients come in and you treat them a dozen times or 24 times or whatever it is, and you get paid and it's fine, but you recognize that if someone came in to inspect the foundation, which is the care plan, they might find flaws. They might find that there's some weaknesses there. And the concern is that, when someone comes in and tries to look closely at your care plan, they find that it's going to have fatal flaws and the whole thing's going to come tumbling down. And you can't rationalize or explain why the 12th visit was necessary or the 18th visit or that re-exam or what have you, or why you were doing these therapies. or why they needed 9941 instead of a 9940. All of that can be outlined and laid out when you set up your care plan. So I guess actually Christy already introduced me, so that's me. And there's a picture of me a year old now. Again, I have a lot of certifications, but I'm a chiropractor, and I want to try to help you bridge the gap between what a chiropractor wants to do and wants to do in their work, and those people on the other side who are looking at why they shouldn't pay or what's wrong with your records, or trying to find reasons to not give you the money that you're due for the care that you provide. So I want to bridge the gap between auditors and chiropractors. I want to do both for you. So this is what we're going to discuss today. We're going to try to prove medical necessity. I'm going to give you a formula for providing proof that care is medically necessary, so that you can feel confident that if anyone picks any one service that you deliver, they can see exactly what they need to see in order to feel like it does what it needs to do. I'm also going to share with you how to develop clinically meaningful goals. So these are goals that you and the patient resonate with and understand, and they make sense. And somebody who doesn't even understand the case can look at and understand very clearly and look at them and go, okay, that's what their goal was. Here's where they are and here's where they're going. And so it all just comes together. And then we're going to focus on bringing this into a care plan. And that's kind of the purpose of today, is to put together a good, solid care plan that forms a foundation, again, for all the notes that follow for an entire episode of care. So I want you to think about if you were sitting in your office one day and in walks some folks with those windbreakers with the big yellow letters on the back, says FBI, and they come in and say, hey, listen, we got some reports that you were doing something wrong, and we want to take a look. We want to, give us your records. You can't hide anything now. We're here already. Just hand them over. And would you be frightened? Would you be able to sleep that night saying, you know what, they can look all they want. I know I wasn't doing anything. I've got nothing to hide. Or is your documentation a weakness that can be exploited? So I want you to feel like your documentation is actually a shield that protects you from liability and from failed audits. I want you to feel safe because of your records, not that it's a place that can be exploited. I want you to think if you were a knight on a field, and you were going into battle, and you had your entire, the helmet, the shoulder, the breastplate, the gauntlets, whatever, and you had your armor ready to go, and you were going out to battle in the Middle Ages. But there was this one spot in your armor where, in order to have some flexibility, you had to have a gap down here under your arm. And a really skilled archer on the opposing side could pinpoint that spot, aim very carefully, and just get that arrow right. If they get it just right under your arm, when your arm is raised just right, it's going to hit a vital organ and you're a goner and you lose the battle. Is your documentation something that you feel like is pretty good, but there's this weak spot here, or there's this thing missing there? I want you to fill in all the little gaps and protect all of your vulnerable points, so that when and if you were ever attacked based on your record keeping, you would be able to march into battle confident that you're protected, and that you're safe. So your documentation is a shield. I want you to feel like it's one of your strengths in your practice, not something that can be exploited by others. So let's talk about medical necessity, because that's what this boils down to. I don't want anyone to ever look at your care and say, sorry, that wasn't medically necessary. You haven't documented the necessity for that service, so we don't want to pay you for it. Or so you were fraudulent in providing those services and the state board wants to come after you or something. Medicare, which is sort of the gold standard for healthcare in the United States, has a definition of medical necessity. And they say that it is services or items reasonable and necessary for the diagnosis or treatment of illness or injury, or to improve the functioning of a malformed body member. And so I put in the word functioning in bold, because that's really the key here. If I could end the webinar now, I'd say create records that show loss of function and that show improvement in function over time. So the reason they came in is because they lost some sort of function, the ability to do something. And your care can show that it helps them learn to do that thing again, or be able to restore that function. That's the short answer to what is medical necessity: loss of function and care that provides an improvement in function. So how can you prove this, though? So there's a little bit more to it. It's not as simple as that. There's a formula you can follow that I will give you that will help you build a structure that helps you prove medical necessity. And so I want you to think about your significant other, okay? Your spouse, perhaps, or someone that you've been in a relationship for a long time, and your anniversary is coming up, okay? And it's time to provide them with a gift. It's time to get them something to make them feel special. Now, if you're really in tune with your significant other, then you will know what they want. You'll be able to interpret, you know what, I know that they like this, but not that. And so I'm going to find something like this. And I know that if I get that, that's not what they want. For example, if someone got me a jar of pickles, that's it. The relationship's over because I despise pickles. I'm just not a pickle person, So let's say that you go out of your way and you buy your wife a pair of diamond earrings, okay? Diamond earrings, because everybody knows that diamonds are a girl's best friend. They're beautiful. They're expensive. And so you go out and buy a pair of diamond earrings and you wrap it up perfectly and you put the bow on there and you hand it over to her and you say, this is what you need. That these earrings are the perfect, beautiful gift for you. So let's say though that you provide them to her and she says, well, thanks, these are lovely, but you know what? I don't really care for diamonds. I don't like the white, the sparkly. I want something that's more colorful, like opals, for example, like those blue opals that have all the different sheens when they do light. And some of you know, I don't know jewelry that well, but opals are super cheap. Opals cost next to nothing, like, $20, you get a nice pair of opal earrings. $10,000 get you a nice pair of diamond earrings or something. So the point is, if you know your partner well enough, you'll give them what they really like, which is opals in this case, and not diamonds. And you don't have to spend all that extra time and money. In other words, when it comes to records, you see examples where people will say, oh, the key is to document everything you can and put in all these references and quote all these articles and so on and make this 10 pages per visit. That's not necessary. That's not really what they want. That's what you think they want, perhaps, but I'm going to show you what they really want, which is just opals, okay? So let's get into it here. I've developed this thing I call the chain of medical necessity, all right? And the chain of medical necessity consists of 6 links in this chain. These links, basically, they're dependent on each other. And if each link is there, you're going to be able to prove medical necessity much better. It's going to show a stronger case that the care is medically necessary, and it's going to support the need for the care that follows. So these links in this chain include history of onset, a patient complaint, exam findings, a diagnosis, a treatment plan, and progress. And I have to have a disclaimer here. I made these up, all right? This is a combination of my experience, coming through Medicare stuff, working on audits, talking to state boards, doing presentations. So this is my own kind of interpretation of it. But what I feel is if you were to take any single service and you were to apply this chain of medical necessity, you would find that that if these elements are all there, it's going to be easy to defend this case, easy to defend that service. Okay. So let's take each one of these and go a little deeper. Let's look at history of onset first. The first link in the chain. This is where you establish why the patient has a complaint at the very beginning. So let's just take a service. Let's say that I delivered 98940, okay, on any given date. Let's say yesterday I saw a patient and I delivered 98940, which is 1 to 2 region chiropractic manipulative treatment. The first thing that I would look for to prove medical necessity for that was, did the patient have a complaint? And then if it was an acute case, I would look for mechanism of trauma that caused the complaint. Like, the patient slipped and fell and they hurt their neck and shoulder as a result, or they were in a car accident and they got hurt. Now, we know that for chronic patients, there's typically not a trauma. There's no mechanism specific to that incident. It just kind of gradually became a problem. So for chronic patients, rather than, say, well, they fell and slipped, say, well, the reason they came in today was because they said that this triggered their desire to come in. So in other words, try to establish why they decided to come in now instead of waiting a little longer or coming in sooner. Drill the patient until they give you an answer, of why they chose to seek care for chronic issues. And that may help you establish a history of onset, a beginning point, because payers like to see a beginning point. They prefer it. If you still can't establish one, it's just insidious. There's no real beginning. That's okay. It just means this link in the chain is weaker. Okay, but it's stronger if you have it. So try your best to get it. It's easy for acute because it's a mechanism of trauma. For chronic, just try to establish why they chose now. Okay. The second link in this chain is the patient complaint, followed by the exam findings. And I left these together because if the patient comes in and says, my neck hurts, and then there's an exam on the neck, that makes sense. I worked many years ago for a doctor as I was an associate, and we did these super thorough exams, and we do like 20 orthopedic tests, and we would do range of motion on the entire spine and a few extremities, every patient. And they got sent to the fraud unit, and we got investigated because the patients say, my neck hurts, and we'd be examining their hips and their knees and their low back, and there's no reason for that exam. We can't justify the need for it because there's no complaint in those areas. Payers, for the most part, pay for areas where there's a complaint. And even if you can say, well, there's a link between the knee and the hip, they need to see a direct causal link, okay? And it needs to be well established in order for you to justify the need to examine more than what is, what is linked clearly. So this is where you establish the functional loss. This is where you say, well, the patient's complaint keeps them from sleeping or lifting or walking or sitting or whatever it is. And in the exam findings, you can say, well, the range of motion is reduced here and they have tenderness here and these muscles don't work there. So this is where you establish that functional loss, okay? And if both of these links are here, the argument is much stronger. If you have no complaint, but you do an exam, or if you have a complaint and you don't examine that area, that weakens the case, okay? Now, the fourth link in the chain is the diagnosis. This is where we establish the explanation for the symptoms. We take the history in the exam and we mesh them together and we mold them and smash them up and we look and say, what do we got? And it looks like we've got this diagnosis. So we establish the need for the care. We say, this is the problem we're trying to fix, okay? And so the diagnosis should be the explanation for why all the care is coming, what we're going to recommend in a few minutes. And that's the fifth link in the chain, the treatment plan. The treatment plan needs to be appropriate for the diagnosis. So if your diagnosis is neck pain and the treatment plan says 50 visits, that seems excessive. If your treatment plan is, if your diagnosis says there's 4 sprains and strains and there's some torn tissues and there's spasms and they've got neurologic damage and all this stuff and you only want to treat them for a week, that also is inappropriate. So make sure that your diagnosis substantiates the plan or the duration of frequency especially, and the services are going to be provided. Care that's given just because it's your technique, I'm a full spine adjuster, so I'm always going to bill 9942. That doesn't fly. Technique doesn't establish medical necessity. If it's your philosophy, well, in order to balance the body, I need to adjust the feet, even though they have no foot complaints, and that, even though their only complaint was the neck, that can be your philosophical belief and approach, and you and the patient can negotiate how to provide that care, but the payers need to see a direct link regardless of your philosophical approach to health. And if it's just routine, you say, well, I don't know, everybody comes into my office, gets a roller table, and so I'm going to bill 97012 for mechanical traction every time, every visit, just because it's routine. That doesn't make it medically necessary either, because you have the equipment or it's just part of what you always do. Treatment should also transition from passive to active. Several payers have policies that say we expect to see that patients begin with more passive treatment and those things disappear as their pain and so on gets under control, and you can push them into more active treatment. So we might typically want to see someone with an acute problem have e-stim and maybe ultrasound at the beginning of care, but after 4 weeks, possibly 6 or 8, those are gone, and the focus is much more on the exercises and therapeutic procedures. Okay, and so a treatment plan that starts with therapeutic procedures and passive modalities right at the beginning and has 6 services all done at every visit, all the way through from the first visit to the 30th, doesn't show progress very well. We might expect to see more heavy on the passive and then more heavy on the active at the end, and they kind of transition in and out. Also, it's important to avoid cookie cutter care. If I have 10 different patients and I audit 10 charts and they all have the exact same care plan outlined for them, regardless of their age, the seriousness of their problem, their comorbidities, whatever, that looks bad. We would expect that 80-year-olds with diabetes and severe trauma would need more care than a 12-year-old who is pretty healthy and has a minor first-time complaint. And so it's important to avoid cookie cutter care and set up care plans that are specific to different patients. We're going to elaborate on treatment plans here for the last part of this presentation, so stay tuned. We're going to get to this even heavier. This is just a 5th link in the chain. The 6th link in the chain is progress. It's essential that the daily visits that follow that initial visit show changes and progress and movement. Remember I said that the short definition of medical necessity is functional loss, which is shown through the history and the exam, and then functional gains, which is shown through the progress, through the re-exams, through the daily visits, where you say, the patient said they can only sleep for 8 hours, or they can only sleep for 2 hours, but now they can get up to 4. And one day we hope to get them to 8. Those are functional gains, and that is a great way to justify ongoing care. The goals that are set need to be specific for each patient, and they need to be measurable. This is essential, and I'm going to talk to you quite a bit about goals here for a few minutes, about how to make goals specific and measurable. My favorite way to do that is with the use of outcome assessment tools. Examples will be the Oswestry, the Bournemouth questionnaire, the Neck Disability Index, the Functional Rating Index. Those are all great tools to quantify functional progress. And so we take their function, like their inability to sit or to walk, and we quantify, we assign a numeric value to it, which makes it easier to measure and easier to communicate with others, because numbers are the universal language. Everybody knows that 10 is more than 5, and so on. Goals must be evaluated and updated over time. A critical mistake I see too often in records is, look, I had goals, I got this boilerplate list of 10 goals, and I listed them all out, and here they are. And they have to be updated. If you just list them out and then you never talk about them again, especially at re-exams or at the end of care, they have very little value. The whole point of having goals is to talk about them. In fact, I would argue that the whole purpose of a re-exam is to discuss the goals, not even so much about the findings. I mean, yeah, it's important to show that the findings improved, but the most important part of a re-exam is to talk about the goals you'd set a few weeks before and discuss them and change them if necessary. So those are the 6 links in the chain. If they're all there, terrific. You're going to have a much better chance of defending your care as medically necessary. If one of them is weak or missing, you might still be able to prove it's medically necessary, but it's a lot weaker. And so you have a much better chance if you can clearly show all 6 of these. So this is the challenge for you. After this webinar is over, go pick up the last chart that you filled out. Look at the last service you billed. Maybe it was eSTIM or an adjustment or an exercise. And then look and ask yourself honestly, if I look through these records, can I find all 6 links in this chain just for the service? Just for this one service, can I find all the links? So if the exercise was stretching of the neck, could you find that they came in with a neck complaint that began after they slipped and fell, and that the neck was examined and found some problems like muscle issues or something, that there was a neck diagnosis like spasm of the muscles in the neck, that there was a treatment plan to address it, which says, we're going to do these exercises and here's the purpose. We're going to get the range of motion up from 15 degrees up to 40. And you can measure that with progress. Do daily visits. You say, hey, they're now the range of motion is 25, and now it's 35, and now it's back to 40, and now we release them from care. So if all those things are in there and tells that whole story, that's terrific, because that's going to make the case much, much stronger and make it much easier to prove that it was medically necessary. Okay. So here's an example of a case I was auditing, a records I was reviewing for a client where they wanted to prove progress. So they added this statement to all their notes. Every patient, in fact, had this in the records. It says functional improvements have been achieved in many areas of his life, which is great, because I told you need to have functional improvements. And so they made a list of all of the functional improvements that the patient has made as a result of care. And this is a lot of improvements. If you just kind of read through this paragraph, it says the patient's more relaxed, more rested, stronger, more alert. I highlighted their better memory. Well, that's cool. I wish my chiropractic treatment helped my memory. I should go see this doc maybe, because I don't remember what, my name sometimes. You go through this improved coordination, improved bowel movements. I highlighted improved immunity. And then I start to wonder, well, wait, how is this doctor measuring this patient's response? Like, how do they know this patient has better immunity? Did they expose them to COVID-19 and then test them and find out they were still negative? It's a little odd, but okay, maybe your patients did have better immunity as a result of your chiropractic care. And then you go on, and you can see in the last line, it talks about improved sexual function, improved fertility. And now I really wonder how this was tested. How did you measure the patient's fertility and their sexual function? How does a doctor know this stuff? So this is a bit overkill, right? I think that 2 or 3 things that the patient says they have trouble with, like walking and lifting, those are great things to measure. This is a little bit excessive. Now, this is a photo of me and my children last summer. This was last August. We did a road trip. And there's my 6 kids. This photo was taken. I was in between spouses at the time, so I'm working on it right now, looking for the replacement. I've about almost sealed the deal here. There's my 6 kids. So we went, me and 6 kids in a minivan, and we drove 800 miles from where I live, which is in Utah, to the coast of Oregon, which is about 900 miles actually from here to there. And in order to go on this road trip, we had to plan it out. We had to sit down and go, okay, guys, we're starting here and we need to go up Interstate 15. And then we get into Idaho. We're going to turn westward and go on Interstate 84 and go through Oregon and then go all the way through until we hit the coastline on the coast of Oregon, which is a beautiful place. In fact, this particular picture was taken on one of the few days where the sun was out there, but it's still a beautiful place. So the point is that we had to plan our trip and determine, okay, look, we don't want to make the whole trip at once. So we're going to stop in Boise, Idaho, which is roughly halfway. We're going to stop in Boise and we're going to stay overnight in the hotel. We're going to get gas and we're going to get dinner. And in fact, in between, maybe every 2 to 3 hours during the drive, we're going to stop and make sure everyone goes to the potty and, everyone is fed, and we'll get out once in a while and look around and go, let's see, is home back that way? And the coast of Oregon is this way? Yep, it is. So we can make sure we're facing the right direction. And maybe we look at the road conditions and we determine, hey, there's one of the roads is washed out, or there was a blizzard or a forest fire. We have to take a different route, or we have to discontinue our trip and go another time, or go to an airport and hop on a plane or something. So some of you think this is overly indulgent for me to tell you all these details about this road trip with my kids, but it has a purpose, and this is it. It's very much like a chiropractic episode of care, okay? This road trip with my kids is just like that, where we have this initial evaluation, or we begin the trip, and we get in the car in the driveway at the house, and we say, okay, guys, let's go. And we pull out the map, and we map out the route, and we say, okay, we're going to go south on Spinal Stenosis Road, then we're going to turn left on Disc Degeneration Highway, and midpoint of this journey, we're going to stop and do an interim evaluation. Each of the little circles with a T in it represent treatment visits or daily visits. So that might be, I'm driving along through Idaho and I go, hey, there's milepost 157. And, an hour later, there's milepost 206 or something like that. And I can show that we've gotten closer to our destination because we've put more distance on the odometer, and we've made movement. So the question is, if I pull up 2 of your daily visits in your episode of care for a patient, and I look at a visit from the beginning of March and one from the end of March, do they show change? Is there progress? Have you gotten closer to your destination? Are you closer to Boise or even the Oregon coast? Or are you in Boise right now and you're doing the re-exam? You're halfway through your journey and you stop and you evaluate the patient. You say, we started out with these goals. We wanted to get this far. We wanted to make this much progress. We wanted to change these functions. And you evaluate them and talk about them, and you re-examine the patient. And you go, based upon this, we're not doing too well. So we're going to, instead of going straight like we had planned, we're going to turn south on Neuropathy Lane, which means maybe we're going to add different exercises, or we're going to go get an MRI, or we're going to discontinue a certain service, or decrease the frequency of visits, or increase them. Something changes potentially. So you can set up a care plan that covers a long episode of care, and you don't have to stick to it. You don't have to lock everyone into that plan regardless of how they respond. You evaluate them to determine if you should change course. Or, with my kids, maybe the road's closed and we have to stop and go back. Or you could release a patient from care early, saying this is as far as we're going to get. But we did get this far. We got 800 miles. We have 300 more to go, or whatever it is. And when you get to the end of the journey, which is the discharge evaluation at the bottom right of your screen, then you can say we've done it. We've delivered care that has accomplished the purpose. The patient's function is improved. Their exam findings are better. They're happy with the results. Or with my kids, we're on the beach. There's the ocean right there. If any of you have never been, I encourage you one day to go to Astoria, Oregon, or down to Cannon Beach, which is where they filmed The Goonies. All right. So just go check it out. If some of you don't know what I'm talking about, too bad. Google it, The Goonies, a great movie from the 80s. So that was all filmed on the Oregon coast. So this is how I want you to look at your care. When I talk about setting up care plans for your patients, I want you to think about planning out a road trip and saying, we're going to start here, we're going to end here, and we're going to check our progress in the middle. And the way we're going to show is through these daily visits, or these movements towards that long-term outcome. So that's the principle I want you to understand as we talk about how to set up a really solid care plan, okay? Now, one of the backbones of a solid care plan is, in this case, it's a 3-legged stool. There are 3 elements we want to have, especially when we talk about how long we're going to treat a patient. Now, perhaps the most important one is the yellow circle, which says the individual clinical expertise. In other words, I'm the doctor, I'm seeing the patient. The most important factor here is what I think should happen. I went to a bunch of school. I have the student loan debt to prove it. I got the diplomas on my wall. I got my license. I'm the one who's taking care of the patient. I need to determine what's best for them. However, that should also be combined with the bottom left, which is the patient's expectations, the payer's expectations, and even policymakers. So your state board, Blue Cross, and the patient, all of them need to be considered as you put together care plans. For example, Aetna says they only want to see modalities at the beginning of care, not the end. You need to consider that as you plan things out. And you don't have to do it that way. You can override the payer's expectations, but that could get you into trouble. They could take extra close scrutiny and look at you and say, hey, this is what we cover, and you didn't do it. And so you need to consider that. The patient might say, doc, listen, I want to be seen for 2 weeks and that's it. You can't force them to treat for 4 weeks if they want to be seen for 2, and so on. Now, those are great. If you can overlap both of those, your expertise along with the third party's expectations, that's going to make for a best practice. It's going to make your case a lot stronger. However, if you can combine it with the third circle here, which is the best research evidence, that's going to take it even further. The best research evidence is the third leg of the stool, and it's going to bring it into balance. So if you can say, look, my care is based upon my expertise, what the payer and the patient and all them expect, and here's research to back it up, and here's some published, evidence-based stuff, that's going to make your case best practices. Okay, so let me give you some examples of that. Clinical Compass is an entity. I used to sit on the board for, I think I was there for 4, maybe 5 years. And those guys are, you think I'm a smarty pants. Those guys are the smartest people I've ever been around. And it was intimidating to sit in their presence and talk about how they could pull together all the research evidence and help provide funding to get more information out there to help support chiropractic care. And here are just a couple of articles. There's a whole bunch. You can go to clinicalcompass.org and check it out. These 2 articles in the blue box are some that I think are really helpful in establishing care plans to provide the best research evidence to support the care plans that I want to provide to my patients. And they align well with my clinical expertise and what most payers are looking for. And so it just makes my case stronger when I reference these or use these. And these are both available from JMPT Online. So the Journal of Manipulative and Physiologic Therapeutics made these available for free very generously. And I encourage you to go check it out. Go to clinicalcompass.org. There's a bunch of resources there. Let me just take you through a little bit from both of these articles so we can talk about how they're going to influence the care plans that you and I are going to set up, okay? So first, in that first article, it was published back in 2016. It talked about some evidence-based guidelines for basically more or less for duration and frequency of care in a chiropractic setting. And one of the elements of that paper I thought was helpful in establishing care plans is it came up with 3 lists. Okay, and this screen is the first of the 3 lists. It's complicating factors that can justify ongoing care. So the first list is patient characteristics. In other words, if patients have these characteristics and they're documented in the record, that can help establish why that patient needs more care than average. So for example, patients who are older, pregnant, lifestyle habits, obesity, work activities, if they lift and twist all day long with heavy weight, that may justify more care than if they don't. If they're obscenely pregnant and they're gigantic and they're just having a hard time getting around, if they've delayed treatment for more than a week, all of these things are great things to document because the research, this article, establishes those are complicating factors that can prove the patient needs more care. Okay, so that's the first list, patient characteristics. The second list in this article was injury characteristics. If the injury was particularly severe, or if there's been more than 3 previous episodes, or if the signs and symptoms are very severe, or lots of exacerbations, or, and this one is kind of important, if the patient withdraws from treatment and they are unable to sustain maximum therapeutic improvement, they withdraw from treatment and they regress, that may be justification for ongoing care, okay? So I strongly encourage you to document these elements if they're present in the case that you're evaluating when you set up your care plan. The third list is elements of the history that can be complicating factors that can justify ongoing treatment. If their history includes pre-existing pathologies, a history of lost time, and I'm not talking about time travel, I'm talking about lost time at work. They've tried treatment before, they have congenital anomalies, the symptoms persist despite other treatments. All of these things in their history may help justify the need for ongoing care beyond what would be typical for a case that presented otherwise. Okay, so those are the 3 lists that I want you to consider as you put together your care plans. Document and reference these reasons or collect this in your history to help support the medical necessity for your case, for your care. Now, this screen, and actually the next 3, are the algorithms from this article that we're talking about, these low back guidelines. And this is the acute care algorithm. There's another one for chronic care. And I'm not going to go through all the details with you, but you can look at the slides later on. Basically, the way these things work is a rectangle is an action step, and the diamonds are decision points. And so the diamond has a yes or no, and you decide based on that where you go next. And so the gist of this one is that the best research evidence out there based on this article is that a box 5, if you can see kind of in the center of your screen, it's box 5. You should begin a therapeutic trial of up to 12 visits within 4 weeks. So I was working with a clinic and they were saying that their routine is to treat patients daily for 3 weeks. The first 3 weeks of care, they see them every day. And that is fine if that's what you want to do. And if you believe your patient is going to benefit from that, by all means, go ahead and provide that care. And if the patient agrees to it and they see the value in it, go ahead and do it. You're going to have a hard time, however, finding research evidence to support that type of care. And so you're missing one of the legs of the stool. That's not to say you can't do it. I'm just saying that if you want research that supports a certain frequency of visits, 12 visits up to 12 within 4 weeks is a good guideline to follow. Okay, and I think for most of us, that's enough. And that's a trial. I really like the word trial here because we don't want payers to think that we're doing cookie cutter care where we do the same thing for everybody no matter what. We like to say, we think this patient might need 12 weeks of care, but we're going to put them on 4-week trials. And the first 4-week trial, we're going to see them 12 times. That's reasonable based upon this research evidence, okay? And then another key on this screen on the algorithm is at the midpoint of that 4 weeks, is there improvement evident? That's box number 7, or the diamond as number 7 on the left, is improvement evident at midpoint, okay? So it's a really great idea to do a re-exam at 2 weeks based upon this article. Maybe not even a full re-exam, just a quick assessment of improvement. Maybe it's not a billable exam, maybe it is. And if there is not improvement at the midpoint, then it's a good idea to consider changing a treatment, doing a further diagnosis, or referring them out to someone else. That's box 9. And that's great if you can follow that pathway and show that you don't treat all patients regardless of how they respond, that sometimes you consider alternatives if they're not responding favorably. However, let's say that they are improving and their symptoms haven't resolved. This algorithm suggests that you should continue and finish that 4-week trial. And then at the end of the 4 weeks, you move to the top of this screen here with you do a re-exam at the end of 4 weeks and you say, okay, has maximum therapeutic benefit been achieved? And if it has, it says you can release them from care. And if you release them from care and you can show that they have functional loss and they are unable to sustain the benefits of the care due to a trial withdrawal, if you follow the pathway kind of down the center and right of your screen, it basically takes you either to treat the patient as a chronic patient or to release them to home care and maybe transition to wellness. And so that's kind of that pathway if you find that you can't get them any better, so you do a trial withdrawal and they regress. Okay, so you may be able to justify ongoing treatment based upon that approach. However, let's say that you've treated them for 4 weeks and you decide that they haven't reached maximum therapeutic benefit, that they can further benefit from care. That's going straight down the left-hand side of your screen there. And there, basically, if you feel they can still improve, you may put together another trial of care that's up to 4 weeks long and up to 12 more visits. You can stay in that loop for as long as it's necessary to get the patient better, okay? And if not, then you can refer them out. So this just provides a guideline for you. It's not a cookbook you have to follow. It provides you with different suggestions and approaches, and you don't have to follow it at all. You can rely on your clinical expertise. You just don't have this to support you if you choose to deviate from this, And if you keep this, it's a good, solid foundation to support your care. So let's say this patient wasn't acute and instead they are chronic. Okay, so this is the chronic care algorithm. And without going through all the boxes and stuff on here, the gist of it is it may be appropriate to treat the patient 1 to 4 visits per month on this chronic pathway, as long as you've withdrawn them from care and shown that they will benefit and they will still maintain their benefits. Now, this may not be payable by a third party, but it might be. So it's worth arguing for and trying to follow this pattern. If it resonates with the type of care you want to provide, you can use this to back up that sort of frequency of care for chronic patients. Okay. Now, it does say that if they have a traumatic exacerbation, that you can send them back over to the acute care algorithm and treat them up to 12 visits over 4 weeks. But if you follow this pathway and everything seems to be going smoothly, then it eventually says, okay, you can treat for up to 6 visits perhaps. And if you consider ongoing recurrent care after you've done that trial withdrawal, it may be 1 to 4 visits a month. Reevaluate them at least every 12 visits. If, however, you feel that their symptoms and their goals are being met, you may be able to continue to do care. If you set goals and you can see those goals are getting met, but there's also room for more goals, then you can continue to justify care typically. At some point, you're going to reach a plateau where you can't show any more benefits or progress. And that's when you need to consider transitioning to wellness, give them as much home care as you can, and away you go. Now, this is just a kind of a quick synopsis of this article, this particular guideline. There's another guideline I'd like to show you, actually, and this is the one that just came out about 4 or 5 months ago, actually. And it is a neck guideline, and it's much simpler. The algorithm is much cleaner. And basically, the gist of it is perform an exam, and then consider in the center of your screen, it says a trial of conservative care, 6 to 12 visits. And the orange box on the left says, here's examples of what is acceptable based upon the best research evidence for the types of non-pharmacologic care for 6 to 12 visits. And so those are the types of things that are okay. or that you could justify if you put together a care plan and said, by the way, I use this particular algorithm. This is the second link or reference I gave you on this slide earlier for the article. Okay, and then you evaluate them periodically and determine if there's still responses and you continue on or not. And so this is just another way to manage those care plans. All right, so there's more research out there. There's one other bit of research I want to reference, and this is an article. The reference is at the bottom of your screen. Came out in 2016. The gist of it is this. Care plans should include outcomes. There needs to be measurements, outcomes. And so kind of the middle bullet there says that ADL measures like the Oswestry and so on, those are great. So here's research that says those are great. And if you use them, that's terrific. If you don't use them, that's fine. But if you use them, now you also have evidence to support them. And if they support your care, they're a really great tool to use. Okay, so we're going to talk a little more extensively about those as they can help you set up goals. And so we're going to use this research to kind of help us. What I've got here is a snippet from the Oswestry questionnaire. Okay, I have the revised Oswestry low back pain questionnaire, and I've got 2 of the sections. Now, those of you familiar with the Oswestry, there are 10 sections or questions on there. And then here I have 2 of them. I have the pain question and the standing question. And you can see at the top how the patient answered on the first visit. They said, my pain is moderate and doesn't vary much. And they said, I cannot stand for longer than half an hour without increasing pain. So I treat the patient for 4 weeks, let's say. And then I administer this questionnaire again, and they answer the same questions. And the first one, they say, the pain comes and goes and is very mild. Well, you know what I've just done is I have just proven that the patient responded to care, and I've got some progress there. That their answer to section 1 moved from D to A, so it's improved by several increments. When you look at the other one, the one about standing, the patient went from standing for half an hour to standing for 1 hour. So that clearly shows they improved and progressed, but it also shows they haven't progressed all the way. They can only stand for an hour. And so they like to be able to stand as long as they want. Therefore, I'm going to set a new goal to get them up to be able to answer A instead of just C in this. Okay, so I have basically used the outcome assessment questionnaire to create some short-term goals based upon how they answer each of the sections, each of the questions. And these are functionally based goals that I can measure, that I can measure the difference between half an hour and 1 hour. And that's a really solid way to convey the patient progress and the change. So the question is, how much do outcome assessment scores have to change? So for those of you who are unfamiliar with outcome assessment tools or OATs, most of them have a total. Let's say it was 100 points possible. And if you have 100 points, that means you're really bad. You have all kinds of problems. You have 0 points, it means you're really good. You don't have any functional issues. And so depending on which reference you look at, I think these are safe guidelines to follow on improvement or changes in outcome assessment tools. You may find that some payers have their own guidelines that may be more specific than this. You may not. So this is a good reference to use. I pulled this from the State of Washington Department of Labor and Industries, published a document that this is their principle on that. So basically, if the score goes from 50 down to 48, that's less than a 10% improvement, and it's not significant. You have to have at least a 30% improvement in order for it to be meaningful. So from 50 down to at least 35, or whatever that number would be. A 50% improvement is substantial, though. And so here's what I would suggest you do. If you want to set goals based upon the score of the outcome assessment tool, make it at least 30%, preferably 50% improvement over a certain time period, maybe 4 weeks. Okay. Consider re-administering these questionnaires at a minimum of every 30 days, and also at the midpoint of the initial trial of care, based upon that algorithm we just looked at. And also Medicare, back when they were requiring these as part of the PQRS program, they said that outcome assessment tools were only current for 30 days. And so when they went beyond 30 days, they said those don't count anymore. They don't matter. So you should re-administer them at 30 days to bring a new current one back in. Consider using the overall outcome assessment score as a long-term goal for the entire episode of care, and specific ADLs for the shorter term. That's one way you could use these. I know that overall outcome assessment scores work better for major injuries. The trouble is that for chronic cases, the scores may not show much improvement. And if that's the case, then you may not want to rely as heavily upon them for chronic cases. But they still may be useful. And if you can show that their score hits a plateau, then you can have them withdraw from care and then have them fill out the form again and see if they've gotten worse to show that they may be in need of ongoing chronic care. The other thing is you can focus on other types of measures, such as their dependence on NSAIDs or their objective findings like range of motion, if the outcome assessment scores don't support care, but you feel like they still are benefiting. So here's some examples of some outcome assessment tool-based goals. What I did was I took 7 or 6 of the categories from the Oswestry or the Nexus Ability Index, and I thought these might be good goals based upon how the patient answers those. So if the patient says they have trouble sitting or standing, then maybe you could just make a goal that says enable the patient to sit without pain, or enable the patient to stand without pain. And if you want to get more specific, put a time frame on it and a quantity, be able to sit for so many minutes or stand for so long or walk a certain distance. And so these are examples of what I think are excellent functionally based goals to put in care plans if the patient has these as problems that they're complaining of, functionally based loss, essentially. So here's an example of how that might look in a record. You see, I just took a little snip out of the care plan details in a record. It says, based on the findings, there'll be 3 stages of care. Okay, so I'm breaking my long-term care plan into 3 stages. And each stage is its own little 4-week trial in this 12-week plan. And then I've listed 3 long-term goals. Enable patient to walk without being prevented by pain, enable patient to sit and stand. And then I've added a custom note. So I have software that captures those goals and just uses and pastes in the exact same goals no matter who the patient is. But then I add a specific note to show how this goal pertains to this patient. And for this patient, they can currently walk 25 yards. So that makes it specific to their case, and I can monitor how far they can walk later. The patient can sit for 30 minutes. Looks like I misspelled 30. It's just 30 minutes without pain. Hopefully at a later visit, I can say now they can sit 45 or 60 minutes, or they can sit completely as long as they want with no pain. And so that's how you can use these functionally based goals from the outcome assessments and then talk about them at daily visits periodically to show progress. Talking about these goals periodically is like me saying to my kids, hey guys, you see we just passed through Idaho Falls and the next city is Mountain Home, Idaho. I'm telling them we started back there and now we're getting here. And if you in your records say, hey, when we made the goal, they can only walk 25 yards, now they can walk 50 yards. That's the exact same thing as telling the third party where we're going and how that progress is happening. So at the bottom, I've taken one of those long-term goals at a daily visit later on, and I commented on it. I said, how I had that goal to say they should be able to walk without being prevented by pain? Well, I feel like today they've moved from 50 to 60% of the goal achieved because they can now walk 200 yards, whatever distance you've determined. So these kind of statements at daily visits can be very powerful in establishing the need for the care at those daily encounters. One of the issues chiropractors run into is when payers audit them and say, well, we see you treated them 20 times, we're going to not pay for visits 8 through 15. And you're like, why not those? And they say, well, we don't see much change in those notes. So if every other visit or so, you talk about the long-term goals and you mention how you're focused on them and you explain why you're moving towards them or why you're not, that makes it really hard for payers to just throw out a bunch of visits. You can show that, hey, we got from milepost 157 to 162 to 189 and so on. And you can prove that progress as you mention your long-term goals periodically, not every visit, but once in a while as you move along. Okay. You'll also notice here that I bolded that in the note because I want the auditor to see it really easy. And that's a nice little tip for you. If you ever get audited and they want to see all your records, you might want to print them off and take the time to highlight changes from one visit to the next so that an auditor can see it, because it'll make it really hard for them to deny your care if that's the case. So lousy care plans only address the frequency and duration of visits. They just say, here's my care plan, 3 times a week for 4 weeks and twice a week for 6 weeks. That care plan doesn't have any goals, and that's lousy. Or I've seen care plans that have goals, but the goals are only subjective. Decrease pain. That's it. That's my goal, decrease pain. That's subjective. That doesn't tell me anything useful. Or they don't address function. You set up some sort of care plan that doesn't talk about functional goals, or they're not even measurable. There's no way to measure them, So I'll show you some examples here, okay? First, here's a principle to help you set up a goal. If you can create a goal that has these 4 elements in it, it's a great goal for proving medical necessity. Name an activity, such as sleeping or walking, that the patient will be able to perform, and then set up what conditions they'll be able to do it. So, for example, how far or how long, and then discuss how well they'll be able to do it. Might be without assistance or without increased pain. And then when will it be accomplished? Is that a 2-week goal, a 2-month goal? And then make sure they're patient-centered. They're about things the patient wants and not just what you want. All right. So here's an example from a case that I was working on with a client. They sent me a copy of the records. I actually audited, I think, like 10 records. And this is what they sent me at the very top. And then I took that paragraph and I restated it in the middle of your screen. So short-term goals restated. So here's a little tip for you. When you get audited, instead of giving them a paragraph that reads like a storybook, Give them a list, give them a bullet list or a numeric list, because that makes it so easy to review. Like if I read that paragraph, I can kind of pick out what they are, but now I can see so easily there's 4 things. It's like really quick and easy to spot. Now with this client, what I told them was, look, those goals are not that great, okay? They're not specific, they're not measurable, they're not that functionally based. So here's what I would suggest. Take goal number 1 from reduce pain and change it to reverse verbal numeric rating scale from 8 to 5 out of 10 within 2 weeks. Now that's specific and measurable. And maybe that doesn't directly tie to function, but it certainly is something I can say in 2 weeks, their pain is now 5, therefore my goal has been accomplished. Or their pain is now a 7, so I need to change my goal. Or now their pain is already down to a 3, so we can reevaluate and set up a new goal. Their second one was increase pain-free range of motion, which is fine. I bet you want to do that for your patients. But how much and by what time, So put in specific degrees or a percentage. And then the third and fourth goals here, I think, are fairly worthless. If you have the goal to restore normal vertebral segmental motion, I mean, I guess that's fine, but if you actually accomplish the goal, doesn't that mean you shouldn't adjust them anymore? There's no more chiropractic manipulative treatment. So consider not having that goal if you expect to adjust them beyond when this goal should be achieved. And then the final one is just a repeat to me of number 2. It doesn't really add anything. So I thought this was fairly weak. So this was their initial visit where they set up some short-term goals at the beginning of care. And then 2 weeks later, they saw the patient, did a re-exam, and this is their reassessment. Or with my kids, this is Boise, Idaho. This is the halfway point on the way to the coast. If you read that paragraph, it just says the progress for the patient has been slow but constant. And the funny thing about this was they put that phrase in every patient. I saw 10 charts, and they had different doctors treating different patients, and they all had the exact same phrase, slow but constant. And if you think about it, you could probably say that about almost all your patients, right? The present course of treatment should continue for another 2 weeks, at which time another reevaluation will be done regarding this condition and future course of treatment, which sounds nice when you think about it, but really there's no detail there. So the purpose of the assessment is what happened with the goals? What were the goals and how did it work? And they didn't mention goals at all. So were the goals achieved? And if not, give a reason. Take a moment, an extra for an MRI to figure out why they're not responding. Whatever the reason is, this is where you take a moment to just say, everything's going as expected, or it's not, and here's what we're going to do about it. And that's going to make your case much stronger if you just take that moment to do that, okay? So this was 2 weeks into care. I also got a note, actually still at 2 weeks, they set up new short-term goals, okay? So that sort of implies that whatever those other goals were, they were for 2 weeks, and they should be accomplished, right? So they give me another paragraph, and I got rid of the paragraph and replaced it with these numbers. And so you see there's 5 goals here. And I'm going to pause because it looks like for some of you, we're having a little connectivity thing. Let me give it a second.
It's not you. If you're having a connectivity issue, hit the refresh button at the top of your screen.
Except I can't hear you say that, but that's okay. I'll keep going, and you guys can always watch the recording, those of you who miss it. Here's the deal with these goals. These are good ideas, like help improve strength and endurance and the ability to move, but they're not that useful in terms of establishing medical necessity. So we want to be able to increase strength. So don't make a goal to increase strength if the patient doesn't have loss of strength. That's dumb. Don't say increase endurance unless you have some sort of objective finding to show they've lost endurance and you have a way to measure improved endurance. Like you can help patients with endurance, that's fine, but that particular goal isn't going to help you establish medical necessity, okay? Increase the ability to move affected area. Okay, by how much? And how much was lost? Increase the ability to exert force to the affected area. That sounds like you're punching people in the arm, Like, I'm going to see if I give you a dead arm, I want you to be able to take a harder punch next time. Like, that doesn't make sense. Now, the first goal is a little better. Reduce pain by 10%, but that's not a very big increment, and I want to know by when and where did their pain start? So the problem is reduce pain by 10% can be copied and pasted and used on everybody, but if you say reduce pain from 8 to 4, that can't be used on everybody. That can only be used on the ones who start at 8 and the ones you think can get to 4. And so if you take the moment to customize your notes a little bit more, that will strengthen your case, okay? If you can customize it and make it specific. So here's an example of how you could set this up. This is how you can set up care plan using a software program. And what I've done is in the upper left, I've got 3 stages of care, and I've acuted one. I've highlighted one as acute there in blue. And then below it, I have all the services I plan to provide. And the one highlighted in blue, all the details are in all the boxes to the right. And so I've said I'm going to do during the acute stage, I'm going to do 98940. And then in the right, I've outlined what technique it's going to be. I've outlined the body areas. And in the center, I've outlined the frequency and duration I'm going to deliver that service. And at the bottom, I've selected a goal just for this service, a specific goal just for this particular adjustment. If I were to go down and highlight the electric stim, I also have planned for this phase of care. I could set up different procedure description, different body areas, different frequency, and different goals just for that particular service to show how clean and clear it is. And then in the next stage of care, I might still do adjustments, but the goal's going to change. The goal's going to have a different intention because I will have accomplished part of it before. In this example, range of motion, at first I want to improve it by 50%. During the second stage of care, I want to improve it by 75% from the beginning of care. So those are ways that you can really focus in on each service so that they can't come in and say, well, we'll pay for these two services, but those two we don't think were necessary. Each one can have its own specific description and goals. And once you put it into a software program like this, it automates it and saves it so you don't have to rebuild it every time. You come up with a good care plan template and just reuse it. So here's an example. It says during the strengthening or corrective stage of care, these services will be provided. And you see we have 98940, 97110. And so this would be like the second stage of care. In the first stage, so let me say what I've underlined there says measurable range of motion restriction improved by 50%, reduced pain from 4 to 0. That's the same service I had during the first stage of care. But in the first stage, I said I wanted to improve it by 25% and reduce pain from 8 to 4, something like that. And so the point is the goals can change to show progress, and you can track them separately during stages of care. And then you can have long-term goals. You're focusing on the end point, which is to get them to where they're 100% better. And you can talk about how they progress and move towards that as you move through those stages. So the purpose of what we've been talking about here for the last 55 minutes is we talked about the chain of medical necessity, which is a way that you can kind of come up with 6 things that you can have to prove that the care was medically necessary. And then we spent some time discussing what makes goals useful, using the evidence and the research to help influence that, outcome assessment tools to help us build structured goals. And then once we had those things kind of pulled together, we build that into our solid care plans. And our care plans can focus on stages of care where we have kind of benchmarks. And those benchmarks can have goals at each interval. And those goals can get more intense as you move along. And you can also have long-term goals that span the entire episode of care. And you can talk about them periodically and say, you know, I want to get to there and I've gotten this much closer and this much closer and this much closer. And so if you can convey those things as you move through and push along during an episode of care, just like the road trip with my kids, you'll survive the trip and you'll make it through to the end, and you'll be able to let anyone look it over and say, yeah, I get it. That care was medically necessary. It's to meet with me. I'm going to give you 15 minutes of my time for free. I'm going to do a chart review for you on one single chart for 15 minutes, that I believe is going to follow. Okay, and it'll give you a chance to look at my calendar and pick a time to set up 15 minutes with me. Send me a single chart. I'll review it with you and tell you what I think you can do better. So with that, Christy, I'm going to turn it back over to you because that is all that I have prepared for this lovely audience. I don't hear you, Christy.
Might help if I unmuted myself.
There you go.
If you have a question for Dr. G, as we love to affectionately call him, please submit those now in the chat box. And while we're waiting for that, I'm going to step away from this real quick to remind everybody that we have a webinar on Thursday, Back to Better, and it's going to cover all manner of aspects from legal, compliance, your mindset, getting your staff ready to life after COVID-19, and how to come back better than you were before COVID-19. So if you haven't registered for that yet, you can do it by clicking on, going to ChiroHealthUSA.com/webinars. And it should be right there at the top of the screen. Well, it'll be right below Dr. Gwilliam's face. So I'm going to stop that. We had a couple of people who said, excellent presentation. I put the link to make an appointment with him under the offers tab. So you can just click on that and it gives you directions on how to email your information as well as make an appointment on his calendar. And he is like super smart and really important. I have to make an appointment frequently on his calendar just so I can talk to him now that I don't get to see him as often.
I like that there's not a lot of questions, just a lot of praise coming in. So you guys are welcome. I'm glad you found it useful. I worked hard to make it something I'd want to listen to.
Awesome. Yes. And I mean, like, honestly, you're not going to get the opportunity from anybody else to get a free chart audit. So take advantage. Do not let this opportunity pass you by. As well as, is there anything else you want to add real quick before we go?
I think I've got it all out there. I hope that was helpful to everybody.
Awesome. So again, take advantage of this offer. Spend a couple of minutes with Dr. Gwilliam. If you have any additional questions afterward, or you're watching the recording, if you post your question in the chat log, it emails Dr. Gwilliam your question. So he'll be able to respond to that by email. Y'all have an amazing rest of your day and a fabulous week, and hopefully I'll see you back on Thursday. Bye.
Thanks, everybody. Bye-bye.